Thanks very much. So I'm Haytham Culler. I'm a children's ENT surgeon from Glasgow, and I am now, most importantly, the only thing that stands between you and lunch. Okay? So, I think probably that over the course of this morning, the recurring theme has been recurring themes, hasn't it? And we can probably all agree that whoever we are and wherever we work and whatever our background, tracheostomy care in our own institutions is probably not perfect. Okay, I think we can all agree that. We can all agree that lots of things happen that are bad, and almost always they're due to simple human errors. They're, a blocked tube that wasn't recognised, or somebody not removing a tube that was clearly blocked, or something awful. And the awful thing about them is they are, of course, entirely preventable. They are within our control. This is not falling bits of Russian space debris that are killing patients. This is things that are within our control. And I should have put simple in inverted commas here. These are things which are simple to understand. They are clear. These are the things that make an enormous difference. They are simple to articulate. Whether they are simple to actually implement in practice, I suspect actually is a hell of a lot of work goes into these. And as we've heard, it's many years of work. But they are very simple in principle. So these are the things that can make a big difference. So, why do you need the GTC? Why do you need us? Why can't you just go ahead and do it on your own as an institution? And the answer, of course, is you can go off and do this on your own. The institutions we've heard about today, from the US, from the UK, from Australasia, they have learnt these lessons, they have worked it out for themselves, and they have done it. They've all gone through the same process, interestingly. They've all found the same problems, and they've all found very similar solutions to them. If you want to go through that entire 5 to 10 year process on your own and invest all the time and effort that's required to do that without any help from anyone else, then of course you can do that. But it is an enormous amount of work, much of which has already been done for you by other people. And you could say, okay, well, let's just rip it off the internet. And of course you can do that as well. But you get so much more. You get so much more because you can do that. You can go and find, you can read, as in Tony's paper on what they did at St Mary's, and you can get their bundle and you can do it yourself. But there's actually a hell of a lot more to this than just what you can rip off the internet. You can benefit from other people's experience. And that's not just reading their papers, but it's actually interacting with people who are going through this process, people who have gone through this process a few years ago, people who are still going through this process now. And one of the important things about the collaboration is that we're all in this together, we're all learning at the same time, and we're all benefiting from each other's experience. And the monthly web-based seminars are a chance for everyone to interact and share their experience and ask questions and to speak to the experts and those who've gone through it. You don't have to constantly redo things that other people have already done. Now, there will be educational resources which are provided, which you can see from Melbourne, for example, or from Boston, or from wherever. You may look at those and say, well, they're not suitable for my situation, but you can use them as inspiration for creating your own. The same with protocols. One thing the GTC is not going to tell you what to do is what the protocols should be for your institution, because they will be specific for your institution. But you can see the protocols from Glasgow if you want, and from London, and from Melbourne, and from Boston, and you can see. And you can take the bits from them that you want, and you can leave the bits that you don't like, and you can tailor it to your own circumstance. But all that stuff is there, and it's a lot easier than starting with a blank sheet of paper and creating it all yourself. You could say, okay, I'll get a medical student who's got a few hours, get a little Excel spreadsheet, and we'll have ourselves a database of all our tracheostomy incidents. But, the one thing that's really, really important as a driver for change is proper quality data, which is monitored and which gives you feedback so that you can show where you currently are compared to where you have been and where you want to be, and demonstrating change after interventions, tracking of adverse events, the things that fly under the radar. This is really important. So a good quality database with feedback is a really valuable thing. And in time, once enough institutions have joined and there's enough data in there, you'll be able to get benchmarking data against similar units from the UK, from other parts of Europe, from around the world. Obviously, it takes time to accumulate enough data to do that, but you will be getting benchmarking data back, and that is hugely valuable, and you're absolutely not going to get that if you go on your own. One thing that I think is absolutely essential to point out is that this is a collaboration. This is not people telling you what to do. This is a collaboration. And you in this room are the early adopters. You are the first wave. You are the enthusiasts. You are, dare I say it, the visionaries. So you are exactly the people we need in this collaborative, because you're the people who've seen that this is a problem and you want to sort it out. You're motivated, and almost certainly you've all got examples of good practice, and you've got things that you can share with the rest of the group. So this is a really good opportunity for you to shape the collaborative and share your best practice and innovations with people around the world. And from your hospital's point of view, it is hugely enhancing of status to be able to say that you're the kind of institution that participates in a global quality improvement program like this, because that marks you out, obviously, from the units that don't. So there's a lot of things that you're going to get from participation. But the reason I'm doing this talk is because it comes down to money. And what we've had, very noticeable, certainly in the UK, there's been a little bit of, dare I say it, resistance from some clinicians. I think everybody gets the idea that tracheostomy care is potentially a problem. And everybody gets the idea that simple interventions can make a big difference. So I think everybody signs up to the idea behind the GTC, but a lot of clinicians have come back and said, our hospital's never going to pay. And money seems to be a barrier in the UK. I don't know what it's like in other parts of Europe. Certainly, we didn't feel the need for this talk in the North American launch, where obviously the system is very different and people are very used to paying for professional services and getting things in return. But in the UK NHS, people are just not used to paying money for professional services for things, or at least that's the perception of many clinicians. Let me just make this point, though. What you're not paying for is for Tony to put on a dinner suit and have a fancy dinner, okay? And we all know he likes that, but this does not happen. And the majority of us are going to meetings, and I'm going to the Australasian launch later in the year. I'm paying for that out of my own pocket, my flights, my accommodation. That's not coming from the hospital. It's not coming from anyone. It's coming from my pocket. This one here is coming out of my pocket. The Boston one came out of a slush fund that I have in the department. But I paid for my tracheostomy nurse and my colleague from respiratory medicine to go to Boston to the American launch to get ahead of the game and get us involved as soon as possible. And that's, this is commitment from us to pay. This is not money that's coming from the GTC. This is not coming from your from the fees that you're paying. We've had some very generous donations from individuals and from companies. We've had money from Smiths Medical, for example, and from other companies as well. We've not had any industry influence on what we do. They're non-restricted grants. And they're not a sustainable long-term source of income for the GTC. We don't have external government funding or anything like that. So, the model of how we move forward with this is you pay a fee, and that covers the running costs, and that's how it works. But it's not going for any profit or shareholders, and it's certainly not going for Chateau Latour for Professor Narula. This whole thing has involved many hundreds of hours of work, almost all of it done by a relatively small number of members on the steering committee who've put in a huge amount of time. And that's been done on a very minimal budget made primarily of charitable donations. So we've got it this far, but in order for it to progress and to work long term, then it has to be a subscription model. And the cost is as cheap as chips, as they say. $3,500 US in the first year, $5,000 a year thereafter. For those of you from the UK, £5,000 gets you 2 years membership. That is a bargain. And there are certain costs which are unavoidable, okay? A good quality, robust, secure international database is actually very difficult to set up. The quality of the data, you'll get a talk on the database later, and you will be blown away by the quality of what they've actually come up with. But it complies with legal regulations, the HIPAA regulations in the States, the EU regulations about patient confidential data transfer, a whole load of important legal stuff that had to be dealt with. A very powerful tool that can be expanded and that can give individualized reports to institutions. I mean, this is a hugely complex thing to have developed. And it's almost all been done by people in their own time. But in order to keep this going in the future, it's going to have, it costs money. Web hosting, and all the web-related stuff, again, a lot of it has been developed by people in their own time, but in order to keep it going and be sustainable and of a high quality long-term, then you've got to pay for it. And legal fees, the legal ramifications of patient data crossing from one continent to another are quite significant. So, charitable status as well. So there's a whole load of costs have been incurred, and they are absolutely inevitable. So that's why there's a cost. And in the UK, we have this cash-strapped, government-funded health service where there's always a perception that we're short of money. And so the perception amongst clinicians has been that the NHS will not pay, because this is our hospital manager who, you know, hoards all the gold coins in the basement and doesn't let us ever see them. And the reason that clinicians, I think, have this feeling that the hospital won't pay is because we're used to asking for things and not getting them. We're used to asking for equipment and extra members of staff, and our managers telling us no, right? We're just used to hearing no, and we expect to hear no. But this is different. Paying to participate in a collaborative like this seems odd to some clinicians who've not been involved in quality improvement programmes before. And that includes me, and it will include a lot of people in this room. But actually, as we've heard, quality improvement is not a new thing. It is quite a big thing. There's a lot of it going on, and paying to participate is standard. Managers love quality improvement programmes, okay? And there's loads of them. I went to the hospital manager the general business manager for the hospital. He's called Jamie Redford, and I went to him and I went armed with audit data, adverse events, business case, costings, the number of procedures performed, days in hospital, blah, blah, blah. I had hired a private investigator to tail his wife, and I hadn't really, but you know, photographs of his sleeping children, all kinds of creep. No, I didn't do any of that, but I did consider them. I'll send you the invoice later on. But basically, I went in expecting a huge, big persuasion effort over many weeks. I went in, the conversation lasted literally 30 seconds. I said, Jamie, there's this tracheostomy quality improvement practice, it's an international thing. It's all about avoiding adverse incidents. And he said, fine. He said, send me the details. He said, we do loads of these. He said, these quality improvement things, we've got loads of them. He said, send me all the details by email. That was it. That was it. He didn't want to see the business case. He didn't want to see the numbers. He knew that we do a lot of tracheostomies. He knows intuitively, he's a very bright guy, and he knows there'll be adverse events, and he knows that this will save adverse events, and it will save money for the hospital, and it will, you know, he just knows that because he's done so many, he's heard it so many times before. And the number of things he's currently paying for, he can't tell me because it's well over a dozen. He's approaching 20. There's all kinds of registries and databases and data collection things. There's the cleft cyst, cleft lip and palate database. There's the mandatory paediatric cardiac surgery database. These things, you have to actually employ data entry people. The hospital has to employ data entry people, as well as paying a fee to participate. Civil Eyes is a thing for children's hospitals in the UK. It costs 10 grand a year. The renal registry at £18 a patient rapidly adds up to tens of thousands. This is a quality improvement programme for neonates. This is one for inflammatory bowel disease. We've got an oncology one. We've got a gastro one. We've got, oh God, he couldn't even tell me there are so many of them. I had no idea. So adding a tracheostomy one at 5 grand for 2 years was an absolute no-brainer for him. Most hospitals, and ask around, if you're not aware of this, you'll rapidly become aware of the fact that your hospital almost certainly is signed up to a bunch of QIs already. And certainly in the States, a cost of $100,000 a year would not be unusual, but maybe for some of them in the UK. But costs of 5, 10, 15,000 a year are not unusual at all. Hospital managers are very used to QI, they like them, and they're very used to paying for it. So go and ask them. And they love it, because I think they actually have to report on all this kind of stuff to whoever they report to. And you know, people above the clouds, way above my pay grade. But you know, they have to report on quality improvement activities. It's a really important thing for them to be able to say that they do. And for them to put this little badge on the hospital and say, we participate in the Global Tracheostomy Collaborative, that's a big deal for the hospital, and so it should be. So here's what not to do, because this is what I think, because as well as there is I think some clinicians have had a fear of asking because they expect to be knocked back, okay? And then there are those who've asked and have been knocked back because they've done it wrong. And this is what you don't do, okay? You don't go to the day-to-day middle-level manager. This is the person The person that you see every day that comes and say, why were there only 3 cases on your operating list yesterday? Why is there a 5-day backlog for typing of letters? Why is there, why you used 5 pencils last week when you only budgeted for 4 pencils? That person, okay, who's an important person in the organisation, that person is not the person to ask about this. They don't have the strategic high-level vision of quality improvement on a 5 to 10-year window. They don't know how many QIPs the hospital is paying for, and they don't really see the big picture, because that's not what they're paid for. They're paid to count the pencils, and, they count the pencils. But and of course, if you go and ask this question, then of course they're going to say no. So my suggestion, and this would certainly work in a UK context, I'm not sure about other European countries or the Middle East or elsewhere, but go to someone senior. Go to someone who's high enough up the food chain that they have a strategic level vision about how things are done and about quality improvement on a 5 to 10-year window, okay? And it's not actually about the database. The database is really important. It's you can't demonstrate improvement without measuring. But it's actually so much more than just chucking some data into an American database. This is a global thing. It's a worldwide thing, and it's a quality improvement program. And actually have a chat with, over coffee with your colleagues in the canteen from other disciplines and just ask about other quality improvement programs that you're involved in. And you may be surprised at how many your hospital is currently paying to be part of. One button that you may press, if you go to the managers in, Manchester Children's Hospital and say, well, Glasgow and Great Ormond Street and Birmingham Children's Hospitals are signed up to this, that's probably all you need to do at Manchester Children's Hospital, isn't it? Because they don't want to be left out. You don't want to be the last one. You guys are the enthusiasts, you're the first wave, but that's fine. But you don't want to be one of the last ones to sign up because you have to. The hospital gets to badge itself as a kind of participating hospital in this thing, and that is a major sign of quality, I think, looking around the room. Other things you can do, actually, even if you just collect a bit of audit data in some of the big adult units with a big ICU, a week, 2 weeks, a month, just how many adverse incidents. You go to your manager and say, what happened last week? There was a patient on ICU and this thing happened last week. This near-miss event. How many near misses have you had in the last month in your hospital? It wouldn't take you long to collect a little bit of data, and that's very powerful. 1 or 2 little patient stories, a few little numbers, and your managers instantly will feel the hairs on the back of their neck as they think, ooh, we're sailing close to the wind here. So make it real and immediate and gather a little bit of data. And just contrast the cost of QI membership with one adverse event. The cost to the hospital, and now this is a purely cold-blooded financial argument now, but just the cost to the hospital, not mentioning the actual cost to the patient, the family and everyone involved, but the cost financially to the hospital compared to the cost of QI membership is peanuts. And you can easily make a business case. A big adult unit with a big ICU that's chucking in 200 tracheostomies a year, you save, you have to save 3 patients out of the 200 that you do. 3 patients, 1 day in ICU stay, and you've made your money back. Now, you will obviously save considerably more than that. You'll save a huge amount of money if you can streamline the process, reduce adverse events, reduce ICU stay, reduce hospital stay. It's an absolute no-brainer. It's a no-brainer because it's not just about reducing cost. It's about improving the quality of care for the patients and avoiding adverse events. There really is no downside to this. And this is very interesting, very powerful reading. And if your managers haven't read this already, you need to wave this under their nose because it is an enormous piece of evidence backing up everything that we've said. And at the end of the day, this is a really important thing. And if you need to demonstrate commitment to the management by saying, OK, we'll fund the first year. We'll fund the first year from our department discretionary fund, which is a charitable fund. Maybe you need to demonstrate it to them. I'm hoping it won't come to this, but you may have to do that. I had to demonstrate some commitment by dipping into the charitable funds to pay for travel and accommodation for members of staff to come to the meetings. And by doing that, the management then said, OK, we'll pay the fees for joining the GTC. There are grants available on a local and regional and national level for quality improvement, audit, patient safety. Your managers may know more about where to get these than you do, but there are grants available. So it may be possible to get some grant funding. There's not a huge amount of money, but it might help to kickstart. And ultimately, get a pink gorilla suit and run a marathon. I mean, this is important, This is important stuff. So I think if you demonstrate some commitment to your management, then they may well be willing. That's not me, by the way. they may well be willing to support you years 2, 3 and 4 if you can pay for year 1 and demonstrate that level of commitment. But anyway, I'm hoping that won't be necessary, because at the end of the day, it's all about the patients, isn't it? Thank you very much.